Good afternoon, and welcome to HealthLeaders, the Winning Edge program, our last Winning Edge program of the year. This is a series of webinars touching on the topics and strategies that you need to know most. My name's Eric Wickland. I'm the Senior Editor for Technology and Innovation here at HealthLeaders, and I'm going to be the moderator for today's event. Today's webinar is titled The Winning Edge for Using Technology to Improve Emergency Care. It's a topic near and dear to my heart, and I think we're going to have a great conversation today. Before we get started, I do have a few housekeeping details to go over, just so we get everything right. Note that an on-demand version of this program will be available on our YouTube channel on Friday and can be accessed through our website, healthleadersmedia.com. And you'll notice a couple stories that I will be writing on that as well. To ensure that you can see all the content for this event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you'll find a resources list for today's webinar in the upper right of your screen. Here we've listed the webinar slide deck and some additional materials for you to download, along with a registration link for future Winning Edge events, and they'll be next year. Okay. Now, at the bottom of your console are a few widgets that you can use to submit a question, and we will have a Q&A session at the tail end of this event. Click on that Q&A widget. It may be open already and appear on the left side of your screen. You can submit questions at any time during this hour. However, please note that I'll be looking at those Q&A questions and getting them ready to answer last 10-15 minutes or so of this conversation. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which is a question mark icon and covers common technical issues. Now with that, it's my time. At this time, it's my pleasure to introduce our panelists for today's discussion. I'm going to note here that we have three panelists. One will be joining us very shortly. He's getting back to his office. We have Anthony Roggio, Medical Director of Telehealth for the University of Maryland Medical System. Alan Hsiao, Chief Health Information Officer at the Yale New Haven Health System. And joining us shortly, David Chestek, CMIO of UI Health in Chicago. Thank you all for joining us today. And with that, let's get into the question, into this conversation. And as I mentioned, David will be joining us shortly. For the moment, excuse me, here's the softball. I'm going to introduce the two of you and let you tell us a little bit about your organization. Let us start with Anthony on this one.
Sure. So thank you first off, Eric, for having us here. So my name is Anthony Roggio. I'm an emergency medicine doctor by training, and I work for the University of Maryland Medical System. The system is basically 11 hospitals and 4 freestanding emergency departments across the state of Maryland. We operate, obviously, multiple outpatient clinics as well, about 150 outpatient clinics throughout the state. And we do telehealth in basically every avenue of care, from, or virtual care in every avenue, from pre-hospital to post-hospital, post-acute care. We're involved in some sort of digital realm of healthcare there. That's a very broad 50,000-foot view. I can obviously go into more detail in each of the aspects of it as we go along in the conversation, but that's the system in a nutshell. Alan?
Thank you very much. Alan?
Sure. Thanks, Eric, again, for having me as well. And so I'm from Yale New Haven Health, which is closely affiliated with our Yale School of Medicine, and serve as CHIO for both. And we are a 7-hospital campus organization up and down the coastline of Connecticut, and as well as kind of southern Rhode Island. About 350 ambulatory sites, I think about up to 9 different EDs now, and I actually work clinically on the weekends as a pediatric emergency medicine physician, similar to Anthony, and in our children's ED. And so we certainly always looking for ways to improve efficiency using technology, and definitely really appreciate the topic today.
Okay, great. Yeah, let's jump right into things. And our first question kind of sets the stage for this conversation. As I mentioned, this is a popular topic. The idea of the ED changing, evolving from what you may remember, say, from ER or St. Elsewhere, if we even want to go that farther back. The idea of a very chaotic, frantic place, patients rushing in and out, doctors and nurses going back and forth and all the time. And you're getting these new technologies, AI, clinical care, virtual care, that are changing how the ED works for the better. And that's what I want to get into today. How are you using these new technologies? How is ED evolving for you? The first question is, how has new technology changed the ED space over, say, we can say the past decade? You can choose any time period you want, really, for this. So, Anthony, I'm going to start with you. How have you seen technology change the traditional emergency department?
Sure. So I'll say it's still chaotic, right? I mean, that's clear. The chaos of the ER does not change despite what technologies you add or adjust. The two things that I think I've noticed are, number one, improving access to resources that otherwise were limited or unavailable. So I'm thinking in terms of like virtual care here, bringing consultants in from outside institutions or outside facilities that you wouldn't otherwise be able to get to your emergency department. So over on the Eastern Shore, pretty rural area in Maryland, they generally do not have a lot of neurosurgery cases or even a lot of neurology. So piping those service lines in through the use of virtual care, provider-provider consultations, telehealth, things like that, adding that as a layer of support. The second aspect of it, I think, too, is taking resources that you have and then stretching them so you can accommodate more patients, right? So improving your flow and efficiency through the use of technology through multiple different types, right? So whether it's EMR improvements, whether it's adding AI into your clinical flow and using any voice-to-text software to document your conversations and make life a little bit easier for the nurses and the providers. Or if it's, again, taking maybe a system resource like a telesitter and using that in your emergency department so that you can maybe provide sitter services for more patients and free up your techs to do in-person services, right? Stuff like that. I think those are the biggest things that I've seen over the last year.
Nice. Okay, great. Alan, same question.
Yeah, I definitely echo a lot of what Anthony was sharing. Certainly, technology's come a long way, and I guess I've got some gray hair, so I'll go back maybe a little bit past 10 years in terms of past decade. Where ED used to be was we used to really function in this area where we didn't have a lot of information, right? Whatever the patient could tell us if they were conscious, that's about all we knew because things are locked away in paper charts. And then with the digitization of healthcare, that was a lot of promise there. And now if that X-ray was done in another institution or there was notes done at an outside hospital and the patient is transferred to us for definitive care, we often didn't have that, but now we have that information. But now it's like this information overload, where now we've got hundreds of notes, maybe thousands of notes. You've got HIEs, you've got care everywhere. You've got information from all over, and how do you sort through it all? And so that's what things that really dramatically changed, I feel like. And has also gone up, right? When we were on paper charts, we could kind of scribble a few lines, and then now we can have electronic, and the billers and coders are always after us to write longer notes and put more things. It used to be 10 organ review systems, and this, that, the other thing. Now it's medical decision making. And you're in the heat of the battle in the ED, just trying to keep the patient alive and triage and move to the next fire. It's very tough. So, in addition to the tools that Anthony mentioned, one I think that's probably dramatically changed things for a lot of our physicians and providers has been the use of ambient, and where now we are able to not to worry about taking notes, either physical notes or mental notes, when we're talking with the patient. But after verbally consenting them, it can really, the AI is listening in and can actually create that summary. And sometimes even go one step further, able to remind, pick up things that maybe, we've forgotten. Silly example would be a patient, parents asking me if they could get, their child's 6-month vaccinations while they're here, while we're evaluating it. That wouldn't be appropriate because the child's sick right now, but behind that, we also don't carry all those vaccinations in the ED, and so we quickly dismiss that, no, sorry, you have to follow up with the pediatrician about that. Completely forgot about it, focused on the evaluation of the child, and But as we're going to discharge the patient, and the AI has summarized the note, the AI actually had caught that and put into the discharge plan, follow up with pediatrician for 6-month vaccination. And I would have totally forgotten to put that. There's a nice little example of how AI can take some of the cognitive burden off of busy physicians. We've just got so much to keep track of these days, and I think that's what we're looking to for technology to help, because we've gone from, I think, this information desert to information overload and task and cognitive burden overload. So we're really more of a happy medium where we can focus better on patients.
Yeah. And as we mentioned, that's a frantic environment. Usually your providers are rushing from one patient to another, and to be able to have that information at their fingertips when they get to see that patient is crucial. Now you mentioned, Anthony, bringing in consults, using virtual care to kind of bring in consults when you don't have the specialist there in the ER. One of the bigger issues now is the idea of psych consults in the ER and the ED because so many hospitals are struggling with the number of people coming into their ED needing this type of care that may not be available in the ED immediately. Do you see is virtual care a good channel for this type of consult?
Yeah, absolutely. I think psych is probably the lowest hanging fruit when it comes to bringing a consultant to the ED virtually. There's so much opportunity there. I work at our Midtown campus, which is very inner city Baltimore, very, very, a population that has a lot of care management needs, substance abuse needs, and also psychiatric needs. Unfortunately, we don't have psychiatrists at the Midtown Emergency Department who are doing consultants in person, but we do have a telepsych. And we'll have our psychiatric social workers or our case managers and social workers who are trained in psychiatry or psychology. We'll see the patient, refer the case to our telepsych physician, who then pipes themselves in, sees the patient, and discusses back and forth with them, what's going on today and how they can best get the assistance that they need. That's one of our hospitals. Other hospitals within our system, same deal, just slightly different workflows and tweaking the program, but generally the same idea. Getting a remote consultant and a remote psychiatrist to really handle the patient care and provide recommendations to that in-person ED attending to say, hey, I think this guy needs to be admitted, or hey, let's discharge him and here's some information you can give him, or for follow-up and medication planning, et cetera, that we can put in an actual consult note so you have that for you and be able to take care of the patient appropriately. Yeah. So absolutely, psych is perfect for this.
Good. Alan, I'm going to ask you the same question. Do you see a lot of use for virtual consults to improve the flow of the ED?
Yeah, no, definitely. I think so. Especially if you think about, how you might need very specialized care, like, behavioral health, as Anthony was mentioning, but it could be the, specialist consultant for, endocrinology or neurology that you might not have on all your campuses. But you do have that specialties there. Not something that we have at every hospital, but all of our EDs see children, all right? And so they may need a specialist. And so that's something I think is very powerful that technology can help maybe prevent some patients who would have otherwise been transferred to see that specialist, but maybe can now virtually consult with somebody and be able to kind of care for them more locally near their home. And then only in, if they really need, physical intervention, then transfer them. So I think to Anthony's point, there's a lot of potential, and behavioral health is a great example of low-hanging fruit, where I think there's been growing experience in that area.
Yeah. I mean, the point Alan just made about potentially avoiding transfers, right? I mean, that's such a big component, especially when it comes to, having a large catchment area across state, or across a large portion of the state, or you're in a rural facility where it may take an hour to 2 hours to get to the tertiary care center where you actually, have to get the patient seen. Instead of bringing the patient all the way over there, you can have that patient seen by the, primary transplant surgeon who did the operation, and get them the care at a distance, right? So that's one of the things that we're trying to do at Maryland. We call it virtual first, credentialing as many of our specialists across our system as possible to be able to see these patients in the emergency department or in the inpatient units, and provide the same care as they would, at a distance. Maybe not, obviously not doing the surgery, but providing the recommendations to the primary team, providing the follow-up regimen and plan, adjusting medications or dosages, and again, in coordination with the primary team to help them. So we've been working to credential as many of our providers within our system hospitals as possible to do that. And it does bring down transfers. It does bring down the I guess, length of stay for patients, right? Because they're not waiting for a bed at the tertiary care center, which never happens, right? You get maybe a week or 2 weeks on a waiting list, and good luck if you get there. Yes. And it also allows us, I think, a better patient satisfier too, because now they get to stay in their local hospital. They don't have to worry about getting transported back home or looking for a skilled nursing facility or acute rehab center after they're discharged. That's 100 miles away when they can get it right there where they are with the specialty care that they have.
Yeah. Okay, let's jump to the next question here. Okay, yeah, this is we're going to kind of extend the first question and get a little bit more detailed this time. We've talked about virtual care. We've talked a little bit about AI. What are the new tools and strategies that you're using, and how have they the big question is, how have they improved ED care and clinician workflows? I mean, we all know physician stress, burnout, clinician stress and burnout is a huge thing right now. And a lot of the innovations coming out are designed not only for clinical improvement, but for workflow improvement. And certainly the ED could use a lot of that. I'm going to start with you, Alan, on this one. How does AI, how does virtual care, digital health, how does it improve the workflow for clinicians, and how does it improve ED care for you?
Sure. Yeah. So I think it's been a continuum where then I think we really jumped right with the AI. But so we went from paper charts to electronic, and then you had to make everybody type. So then we added tools like speech to text, right? Natural language processing, and that was pretty decent. And that whatever you spoke, and if you were a fast typist, that saved you a lot. If you were a fast typist, maybe it didn't help that much. But now I think with the ambient AI, especially with the integrated in the EHR that we now have live, it really just takes that cognitive burden and that task off of you, where you have to, take notes. Either some physicians might be in the room with the patient, but really facing the keyboard and the screen, right, and typing away. Where now you can just really look and focus and give your full attention to the patient. And really just dive into the history, read their body language while they're talking, share more of your body language, right? I think you come across as more empathetic and making more eye contact. And for the children, we can make funny faces at them, smile at them, little gestures so they get more comfortable. All these little things I think really build this rapport that the AI is enabling us to do, that we, in a very time constrained, time frame that we usually have, weren't able to do as well when we were, just had to do it on the keyboard or on the computer. Or some doctors might just kind of skip all that and just try to remember because but not, no one can do that quite as well as AI that's actually listening and have the entire transcript and then give you that summarization. So that's why we've gotten so much feedback. We have just under 150 emergency medicine physicians and providers using our tool right now in ambient, and the feedback is just like it's just such a burden lifted off of them. And for some folks who may be interested, a lot of EDs, recognized this early, but didn't have the technology. None of us had the technology, right? A few years ago, so a lot of us, would hire scribes to kind of fill that gap and try to free up the physician. And I can tell you, for us locally in our EDs, as well as other organizations I've heard, have been able to move away from scribes that are terrific, but are very, very hard to scale. So we would have a few providers enjoy scribes, but not the hundreds of physicians that we had working in the EDs. Whereas ambient, AI is a lot easier to scale, and so that's what we're excited about. And then now something that we're still working on, but I think will be available in the future. We're piloting in ambulatory. Will be to actually penned orders. So as you discuss with the patient and say, hey, you know what, I think you need a chest X-ray, we're going to get an EKG, and I'm going to consult nephrology. it can actually start to kind of pen these orders up for you in the electronic medical records when you step out of the room, log into your EHR, and then you can say, yep, you heard me correctly. Actually, no, that's not exactly what I wanted. You could delete that. But it saves you a bunch of clicks, as well as this kind of mental notepad, if you will, while you're caring for the patient. And I think it also will encourage more shared decision making, right? You'll speak out loud a little bit more readily. Some of these things you're thinking about, if you know that the AI is going to pick it up and then save you some time when you put the orders in. So I think I'm excited, cautiously excited that AI is really going to just really improve our patient-physician relationship, and without having to take much more time, we can really improve how they feel about us, how well we communicate with them, how empathetic the ED physician is.
Yeah, it's certainly a new use case for ambient AI. I mean, it's been used in the doctor's office for a while now, the ambulatory office. The doctor-patient relationship has been charted and documented with ambient AI. It's just moving now into nursing and into the ED, which are far more fast-paced and chaotic. Kind of harder maybe for an ambient tool to pick up the right conversations, but you're proving that it could be very valuable in this environment. Okay, Anthony, same question. What are the biggest benefits you're seeing to some of these new technologies, and how are they improving the workflow for clinicians and the experience for patients?
One of the things I've noticed, especially over the last couple of years, is the emphasis that my organization's been placing on data and how we can take the information that we're collecting in our EMR, right? It's kind of passive, right? It's all these points of all these pressure points that we see every single day on a regular basis, anecdotally, clinically, right? I'm sure Dr. Hsiao has the same feeling that I do. Sometimes that there's an issue, but you just can't prove it unless you go deep, dive deep into the data. And being able to take that information out of the EMR now, and we have an excellent data guru. He's Dr. Mark Sutherland. He's one of our EMIM critical care physicians who basically built this epic wizardry of a combination of Tableau and Clarity and Epic all together to show us exactly what are the problems in our emergency department and how we can solve them. So like time to CT, time to lab draw, et cetera, order, et cetera, things like that. And knowing that, take the resources that we have and apply them, number one, more appropriately. But number two, as we are now moving into the next phase of this, using that data for more predictive analytics. When can we expect the highest patient volumes? When can we expect that we're going to need to staff up, whether it be nurses or physicians or techs, so that we can improve and not get a big backlog of patients all of a sudden, on a Thursday afternoon that we didn't expect. And I think that's where I'm seeing a lot. In addition to everything that Dr. Hsiao has been talking about, I think that is really one of the most or largest changes I've noticed over the last few years. I'm seeing that now in the inpatient world and the transfer world, as we're taking predictive analytics to figure out where patients should go in transfers and within our system, and put patients in certain beds, and when we can expect this next patient to come through, or when we can expect a ready bed to be made for someone who's not even here yet, right? Moving that into ED now is kind of the next realm of possibility for us.
Yeah, and certainly one of the potential benefits that we've been talking about is the patient throughput idea. You've got patients in the ED. Will you be able to send them home? Do you have to transfer them up to the ICU or to another department within the hospital? Knowing exactly what facilities you have available for them certainly eliminates or improves one of the bigger bugaboos, the time spent waiting in the ED by patients just for that next phase of care, which I think if you talk to any patient and family is the biggest pain point for them in the EDs. Okay, we talked a little bit about the benefits, and we will get back to more of those benefits as well. Let's talk a little bit about the challenges to introducing new technology to emergency care. What are the hang-ups, or what are the problems you had to overcome in order to use these new tools, AI, virtual care, anything that any predictive analytics. What are the problems you encountered before you got them in there that you had to get around before you could actually use them in the space? Anthony, I'm going to start with you on this one.
Sure. I mean, the biggest is always providers and culture, right? It's asking them to do something new or asking them to change the way that they do something. Trying to convince them that it's the right thing to do is often the most difficult part of this. And they have to struggle through it, multiple meetings, multiple trainings of how to actually use the technology and adjust their workflows to accommodate it, I think is always the biggest hurdle. So in my experience, finding a champion in each of these emergency departments has been really the way to go, because that person can do the hard work for you, and speak on the level of the people who are working there. Because I don't know from beans what my Upper Chesapeake providers have to deal with on a given day, right? The patients that they see in Aberdeen are probably a lot different than the patients I see in inner city Baltimore. So their challenges are different as well. But if I can have a liaison or someone who is in the trenches there, tell them the same things that I'm trying to tell them, but they're going to believe them a little bit better. They're going to be able to explain in a way that makes sense to those providers in that group, or those nurses, or those techs, or whoever we're trying to give the technology to, and then help me or give me feedback and adjust how the workflow really should be. Because a lot of times, I don't think a top-down approach to system change is the right thing. I think you really want to collaborate with the people, boots on the ground, who are going to give you that feedback and allow you to tweak things, and maybe they'll come up with ideas that you didn't think of that will work the problem a little bit better than you thought you could. So I think that champion or that individual there who's really going to help you is kind of the key driver of change for an organization and an emergency department specifically when it comes to culture.
Okay. One follow-up question. Is it different introducing new technology to the ED setting as opposed to introducing technology to another setting in the hospital? The very fact that the ED is so quick and so fast-paced make it more difficult to introduce new tech?
Well, I think the first hurdle is you always want to show them that it's not going to slow them down. Mm-hmm. It's meant to speed them up, right? It's meant to help with their throughput and workflows. So if you can get over that first hurdle, you can usually win the full argument. But yes, it is more of a challenge. I think also emergency docs are sometimes a little more skeptic of new technologies because of the potential for disaster. We don't want to take any chances when it comes to our patients, right? So we want to make sure that they get the care that they need. And some tools help and some tools don't. And being willing to say, sometimes take a loss too and say, listen, this one wasn't working. We're gonna adjust courses. I think an attitude you have to have too.
Yeah, certainly, yeah. Time is of the essence in that department. Okay, Alan, same question, and I know you're going to approach this from the AI angle. Was it a challenge? And I kind of mentioned this before, the idea of the so many different voices, so many different things going on in the ED setting. Can ambient AI fit into that environment? How difficult was it to introduce that technology?
Yeah, great question. Surprisingly, not difficult. I think because, and Dr. Roggio kind of alluded to it already. So it wasn't something being forced down, people's throats. You have to, the way you have to click on 10 review, points of review system. And so there's something, voluntary. And then we're also lucky that we've got quite a few emergency physicians who are very engaged, some formally as informaticians with our health system and our school of medicine, others just very techie savvy people who love technology. And they really serve as natural champions to kind of get the word out and be like, hey, look, give it a try. But, I think it is tough in the ED because people are already so overstretched, time is of the essence, and people are working, overnights and don't have a lot of tolerance for, hey, I need you to orient, this new module for 2 hours, right, post shift or pre-shift. Those things aren't usually going to go very far. And so the easier the tool is to adopt, and then if it's something that is appropriate to be, kind of voluntary, then a lot of times human nature might be, hey, you know what, no one's forcing it, but I heard from my buddy that actually it's worth it. Maybe I will give it a try. And then they try it, and it's easy to save them time. and then they'll use it, then they'll tell their buddy about it. And I think that's sort of how we approach it, is because I think to your point, Eric, we started in ambulatory, and then we're like, hey, this tool might be useful in the ED. And so we had a few of our ED docs try it, and they said, absolutely wonderful, saves a lot of time, it works really well, not hallucinating. And then we said, hey, let's really try to just offer it broadly. And so yes, we do have quite a few ED docs who they are creatures of habit. They've got their macros down. They don't want to try something new. We're not forcing them. But I just looked at our numbers today. We're up to 148 physicians and providers who are using it in the ED on a regular basis, and I think that's a win. And certainly quite a few more docs now able to use AI than we were able to afford to have scribes, for instance. And so that makes us happy that they're now more efficient and hopefully able to enjoy practicing medicine just a little bit better as a result.
Nice. Okay, great. Here's an interesting question we haven't really discussed yet, and I know I wanted to get into this one. The idea that new technology can not only improve care in the ED, but coming into the ED. The idea that you might be able to better understand what your patients are dealing with before they actually get to the ED. So how might new technology improve communications and handoffs between your ambulances and your EMT crews and the ED staff? How can you use these new ideas to understand better what patients are coming into the ED? I'm going to start with you on this one, Anthony.
Sure. So I think there's a very interesting history around EMS communication with the emergency department and how we have really worked for the last, really more than 30 years now, probably. It's all been over radio, right? It's all the box call, the base station call. You get the call come in, you have Dr. Roggio on the line, over, go ahead. And then they give you the story as much as possible. And it's kind of this, it's almost a broken communication and very structured and rigid, which in a way is a good thing because it provides some guardrails, but it doesn't always get the patient what they need. There are many patients who, come to the hospital who, I will say, don't necessarily need to be there in an emergency setting, right? A more appropriate visit would be an urgent care or an outpatient clinic. So many emergency medical service groups have been exploring those kinds of options where they are doing a kind of a screening or a telehealth visit with the patient when the ambulance crew arrives, oftentimes with an emergency trained physician, to really assess the patient's needs, especially if they're a very low acuity type patient where maybe they're only looking for a medication refill or they have a sprained ankle or something like that, and they can get them to a more appropriate setting. Because many of the EDs, especially in the Maryland area, overstaffed. I'm sorry, not overstaffed, understaffed, right? So we don't have enough resources to service all of our patients, and results in prolonged wait times and lots of patients coming in who may decide to leave without being seen, which of course is a bad thing. So we've been trying to do a lot more telehealth, pre-hospital, and we've been working with Caroline County out in Eastern Shore, again, a rural area, it takes like sometimes an hour to transport a patient just from their house to the emergency department, to take those low-level patients and say, hey, do you really need to see this patient in the ED? Or one, can we do this at a distance and maybe you just take care of all the care like this, over a video service? Or two, is there a way we can get this patient into a clinic later today or tomorrow? Can you assist with that? And get case management on the line, get them social services, whatever it takes to address their needs at a distance. The second part of the communication that I've noticed has been kind of changing over the last few years is the movement away from that base station call into a more digital, like text messaging, secure text messaging type service, where you can go back and forth with the EMTs, ask questions, again, not necessarily taking time of the doctor away from his in-person care to go answer the base station call, but getting the alert on his phone, so when he has a moment, he can just look and see what's coming in. The charge nurse in the emergency department sees what's coming in ahead of time. Everybody's on the same page because they all have that same secure messaging application. And they're communicating back and forth with the EMS crew prior to their arrival. So another kind of better avenue. The better communication you have, right? I think the better care you're always going to give, whether that's pre-hospital with EMS or from a clinic or wherever else, we can always do our jobs better the more information that we have. But those are different ways I've seen to kind of address that issue.
Yeah, certainly there have been plenty of stories on mobile integrated health programs, community paramedicine programs, and so on and so forth that, as you say, can eliminate the unnecessary ED transport. And then some of the technology we're using now, which can provide more detailed data from the ambulance, from the EMS crew to the hospital, so that they know this patient is coming in with this condition, that condition. You're getting the vital signs in a better way, so they can prepare better. Now, Alan, same question to you. How are you able to use this technology to better communicate with your EMS drivers or ambulances, and to better prepare your ED for the patient that's coming in?
Yeah, great question. So for us, I think it's still a work in progress, but we actually just moved from a sort of standalone secure message with our EHR, and so now we can securely chat, with each other within the ED. Even have consults that automatically trigger from the consult order in the ED to because we have our EHR tied to our provider physician scheduling platform, so we know who's on call at what time, and then they'll get a secure text message actually gives them the patient information, all that stuff, and really streamline consulting. And then I think to your point, there's a lot of opportunity then to extend that where our, EMTs and our transport team that are out there, and our health system just recently acquired a whole ambulance company, which is why I think it's a work in progress for us. Where I think that will be the next step we should take, is where they're all, carrying, that app. That they can then securely text us. And I think to Dr. Roggio's point, sometimes just knowing about something coming, but don't have to be interrupted in that moment, if it's not that acutely urgent at that second, is really helpful, right? And can just really make things much more efficient. But also if they have a question or something like that, maybe they can even take a picture of the EKG, right, and securely, message it over. And one of us could take a look and be like, yeah, don't worry about it. Oh my gosh, get the license set right over here in the meantime. Why don't you push it, push this or that. I think, that communication is sort of the next natural step, and I think very exciting, for how we can be more efficient in the near future.
Yeah. As you have said, Anthony, it's all about data. Getting the data on the patient to the ED ahead of the patient arriving there, getting data out to the EMS, the paramedics, so that they can better work with the patients they're dealing with, stuff like that. It's all about data, really, when you come down to it.
And a lot of, too, just to jump off that point too, a lot of the crews, whether they're doing telehealth or secure messaging or whatever, I think the idea too is they're also getting better medical direction directly from the provider who's going to receive the patient, right?
Yes.
Especially in rural areas where you have those prolonged transportation times, every second counts sometimes in certain cases. And being able to provide a therapy to a patient earlier because you have that information sooner. Dr. Hsiao, you spoke about EKG transmission, right? You can see that it's a STEMI or a subtle STEMI. You can redirect that EMS crew to the nearest cath lab, as opposed to coming to your emergency department where you may not have those resources available to take care of the patient as well. Or identify a stroke earlier, right?
Yes.
A lot of pre-hospital stroke care has really been advancing over the last few years because of telehealth, portable CAT scanners, and EMS crews that have these kind of not MIH programs, but more emergency response stroke units, where they will go out. If it's a stroke, they'll meet the ambulance halfway, get the scan on the way as they're driving the patient over to the ED, and then sometimes even having TPA on board to push the patient and get within that window of the 3.5 hours or however long you need, depending on your institution, to get the patient the right appropriate care. So that could save time, brain, money, myocardium, whatever you want to save. It's possible the earlier you're able to intervene.
Exactly. It's a perfect use case right there, is how quickly you can get that data to understand the correct cause of treatment Certainly, stroke cases have been a perfect example of the value of telemedicine for quite some time now. Here's an interesting question I always like to ask, just because we can talk about everything and kind of miss the subtle idea that things catch us by surprise. New technology may work better than we think, or it may not work. We may expect something to work and it doesn't. And this question kind of gets to it. And Alan, I'm going to start with you on this one. What has surprised you, good or bad, about the evolution of technology in the ED space? And you can talk about, did you expect AI to work this well, or did you expect more out of it as it has evolved so far?
I was kind of laughing to myself because I think what surprised me was kind of what got me into this in the first place. And I actually started, I started off with never would have dreamed I'd be, in informatics in the CHIO, or have filled us, in any kind of role like that before. But what kind of got me into this space was because in my first year of emergency medicine fellowship, had a, very sick infant come in, who was, hypoxic and really labor breathing. We were thinking about intubating him, but we were trying to get more history. And as I mentioned, everything was on paper back then. And so we didn't have any history. We asked the parents, and they're like, oh, he's healthy. As we're undressing him, he's got a big midline sternotomy incision that's actually pretty well healed. And we're like, okay, what's that all about? Like, he had a heart surgery, but they didn't have any other details, right? And but because I'd been a resident at Yale and had stayed on as a fellow, we had just gone to electronic records in our primary care clinic, and we're still paper in the hospital and in the ED, and as a standalone system. But because I'd been a resident there, I still had my password and username was still active. I logged in, as it'll pull up his record, and I was wondering, was he a hypoplastic left ventricle patient that if we gave oxygen to, we would actually cause shunting and make him even sicker, or is this just a really bad respiratory status and he really needed oxygen right away? And we'll see the information. He had transverse great arteries, full repair. Now with that little bit of information, it's like, now I know how to treat him, and that a little light bulb click is like, that small piece of information can dramatically change patient care, and that's what got me interested in informatics. And what has surprised me was we went from one extreme to the other, as I mentioned, where we had not enough information to just not too much, but just overwhelming amount of information. I can't read every note. The poor residents, trying to get more history from the parents and then try to skim all these notes. And that's where I think there is potential for AI to help with maybe summarization of the chart. And so, that's still early. I don't think many places are doing that yet, but hopefully that will give us a fighting chance, because we've gone from one extreme to the other, where now it's too much information or too much data, and we can't make information out of that data yet because it's too much for the human brain with not enough time. And so maybe, hopefully, AI can help with that.
Yes. Great, thank you. I noticed we have Dr. David Chestek joining us now. I had introduced you a while before, and knowing that you were going to jump in at some point, first of all, I just want to get Anthony to answer this question as well, and then I will get to you. Anthony, what has surprised you about the evolution of the technology in the ED space?
I mean, I agree with Alan, I think 100%. It's the idea that now we have access to so much information and so many different medical records, and whether it's through our HIE programs or whether it's through Care Everywhere or whatever, the time we have to spend now in front of a computer some providers may feel like it's even more burdensome. So the thing that has surprised me is providers have really started to look for ways to get away from that and be more in front of the patient. Right? And when I say surprising, I don't think that's surprising. The technologies that they're adopting are more willing to adopt because of that, right? Because they want to spend more time next to the patient, holding the patient's hands, guiding them through whatever it is they need to be, establishing that rapport. They're more willing to take on these AI programs or digital health programs or whatever you want to call them. And I think this has helped in our cultural shifts that we're trying to create a more digital world, but a world that's also more personal and more patient-centric, right? Getting us from, we're kind of in this middle ground right now where we have so much, and we're just exploring what's possible. I think we're going to start moving towards, the more possible becoming much more patient-centric and much more advantageous to the patient, giving them a better feeling about their own care, giving them their outcomes from their own care. We're scratching the surface right now, but I think the future is looking good, at least in terms of the patient-centered point of view.
Great, thank you. Okay, that's perfect, David. Now, we've been talking about some of the evolution of technologies in the ED space, some of the new stuff that's coming along. Alice talked a lot about ambient AI and how that's been introduced in the setting. We've been talking about, Anthony's been talking about some of the virtual care technology we've seen. Your perspective from UI Health, what are some of the new technologies you're using, and are you surprised, or what has surprised you about whether they've worked for you or whether they don't work in an ED setting?
Yeah, so thanks for having me, and apologies for being just extraordinarily late. I think my co-presenters here have big heavy hitter items. I think maybe just adding on the peripheries. I heard as I jumped on some of the summarization technologies, which is really huge. Can you hear me okay?
We got a lot of feedback on you. Is there something with your speaker you can do to kind of?
Is that any better? Can you hear me okay?
I think so, yeah. Okay.
Okay. So summarization technologies are really powerful. I don't want to repeat anything that anybody has already said, but some of the there are some early adopters using Epic's chart summarization tool, where it'll pull through and give you a problem-based summary of the patient. And for an emergency medicine physician who sort of by definition, hopefully, doesn't know their patient very well, and people come in with many, many chronic, difficult to manage diseases, to be able to thumb through the chart virtually has really been game-changing. None of the technologies are perfect. I had a case recently where, the chart is honestly too big right now to send through these models, at least in their current state, without some performance delays. And so they bound it to either 3 years or 100 notes. And there was a particular patient I saw who had a headache, and exactly 3 years and 1 month ago had an aneurysm that was diagnosed, and then didn't have any visits about that in the last 3 years. And so it didn't show up in the summary, and the patient told me about it, and I was like, why did the summary not tell me? So not to say that it's perfect yet, but I think it's where this has to go. I mean, surfacing this huge breadth of information to find this one little thing that's relevant to my question is really important. And then the other thing I'll say, which I think hopefully folks haven't mentioned yet, but if they have, stop me, is the whole, it's along the same vein of generative AI bounded search. You give it a set of parameters, either the chart itself or the medical literature. So I know companies like OpenAI and Doximity, I think both have tools that search the medical literature for your question and then gives you a direct answer, as opposed to surfacing up a whole medical literature search that you have to then read the abstracts and figure out which one is relevant to you. And it works really good now, and I think it's just going to get better. And I work at UI Health. We have almost every subspecialty service you can imagine. I can get an answer to most questions I have, but most clinically practicing emergency medicine physicians don't have that luxury. And so this almost allows you to have almost any subspecialty as a consult for a quick question or a quick gut check. And I think that is, as it improves, going to be extraordinarily game-changing. There is a risk, particularly if it's an area that you don't know about, kind of by definition, because you're asking a question, you don't know the answer to it, that if it gets something wrong, it's particularly dangerous. But I think, once again, the technology is already good and just getting better. And so I think that's going to be a real game changer, to have a specialty consults anywhere you want for next to nothing.
Yeah, we have talked about the idea that this is all about data. It's all about getting the data, the right data, in the emergency department clinician, so that she can provide care immediately. Because in the ED, that's what we need to do is provide immediate care. So getting that right data, getting that right information to the provider at the right time is key to improving ED traffic. Okay. We talked a little bit about this on and off. One of the more popular terms in technology and innovation is ROI, value. you put a new technology in there, it's got to have value. You've got to be able to prove that it's working better than the old way. So, how do you measure value? How do you measure ROI for a new technology? And this kind of goes back to what are the benefits? So when we talk about ambient AI, perhaps, or chart summarization, or virtual consults, how do you prove the value of this new technology in the ED to your CFO, who's going to want to know how much you're spending on it? Let's start with Anthony on this one.
Sure. So Maryland is a very interesting state when it comes to remuneration and specifically facility fees and hospital payments. We operate under a Medicare healthcare waiver. We call it the global budget. And basically what it means is hospitals get a lump sum payment for every patient, for their entirety of care for the entire year, right? Whether you see 1,000 patients or 100 patients, you get the same amount of money. The idea being that if you can stretch your funding to do more with less, you can save the system money and treat more patients more efficiently, right? There's some little caveats and adjustments here that get made for various aspects of care. But really the only way to make more money as a hospital is through value-based care metrics, right? So improving our length of stays, but also reducing our complications, reducing our readmission rates, and preventing patient deterioration, right? So basically any program that we create has to be viewed through that lens of, we're not making more money by seeing more patients necessarily. So how are we saving money through these value-based care initiatives? And how does our program affect those value-based care options? That's the case we make to our CFOs. And the good side effect, at least in my mind, the good side effect is that usually that also means you're providing better care and more patient-centric care. And as a result, giving our patients better outcomes, right? And ultimately, that's what we want as clinicians, and kind of helps align our own values with this value-based care option of, let's create a program that helps our patients, and oftentimes that will fit into this value-based care model. Or if not, how do we tweak the program to create that financial sustainability going forward, right? So that's our strategy.
Yeah. Does it make things different when we're trying to justify an ED expense?
I think so, because a lot of when it comes to the emergency departments, we have programs like our teletriage program, for example, where we have a clinician in triage, effectively, who's seeing patients across multiple facilities, and as doing this all virtually, right? So he's at home, the patients are coming into the ED, he sees them in triage with the triage nurse, and it's an exorbitant program, right? It takes a lot of money, but it's certainly less money than having an individual sitting there in person in every single triage room with the patients providing the care that way. To justify that expense, we can show morbidity and mortality benefits and readmission benefits by getting the patients, getting on the patients sooner, getting their orders in sooner, getting clinician eyes in front of the patient sooner, preventing their deterioration, which then allows us to continue the program because we can show that there's financial value associated with those metrics that can get fed back into the program and justify its use.
Yeah, perfect. Okay, David, same question. What's the ROI for new technology in the ED space? Oh, you're on mute right now. Ooh. Oh.
I think I should be good now. Can you hear me okay now?
There we go.
Yeah, I was connected to my phone and I disconnected my phone and then I just disconnected everything. Now I connected my computer. So my apologies.
That's the theme of this. That's the theme of this whole thing. Is that technology is good, but it can be a challenge as well.
That's right. Technology is just an enabler. It'll either enable bad behaviors or good behaviors. It'll make more of whatever you've got. So I think when making the case for ROI, I think it's exactly the right question to ask. Everyone's wrestling with right now. My approach is always to start with the problem first instead of the technology. In informatics in general, I can't tell you how many times people put in some request for some alert somewhere and they're jumping to the solution. And I always just, what is the thing that you want to affect? And then let's figure out what the right tool is. And so coming at the CFO with the problem first is always most important, because then we have to all agree that the problem is the problem, and then we can try a small intervention to solve that problem with preset measurable outcomes. And then you have to be objective and say, we either did or didn't move the needle with this small subset, and recognize that we can't always generalize that to an enterprise rollout, but it's better than going in blind. And so then the question becomes not, the first question is not, should we spend $10 million on this thing? The first question is, let's spend $50,000 to see if it works. And we know that we have this problem. And so then when you come back and say, we did exactly what we said we were going to do, and these are our results, and now we need to spend $10 million, and this is what we already agreed to, it's a much easier conversation. And so that measure is sometimes dollars, and increasingly it needs to be, because the healthcare sector is buckling. But it can also be physician satisfaction, it can be patient satisfaction, it can be a particular operational outcome. But I think that strategy of problems first, technologies and solutions second, and measurable outcomes in small bite-sized pilots is really the way to go.
Nice. Okay, same question. How do you prove the value of a technology in the ED space?
Yeah, I mean, definitely echo everything Anthony and David shared. And I think a lot of it, is going to be between, physician wellness, patient satisfaction, and then time, and then hopefully time, translates to better outcomes or maybe financial savings. And so for us, an easy one was, I mentioned earlier, the ability for us, for two of our EDs, actually spend quite a bit on scribes, and they were able to no longer do that, and then now able to offer this ambient technology to a larger number of physicians. And they had, I think, already done the back of the envelope calculations in the past that they needed to have scribes for certain providers on very busy shifts, because that enabled them to see extra patients, or maybe it's a retention thing. But so there's the ROI there that I think now that hopefully AI is going to help democratize by making it a bit cheaper, that kind of help and support for physicians over a broader number. And then certainly for us now looking at how much time people spending in documentation. People often talk about time after hours, outside of scheduled hours, and it can be tough, especially to kind of calculate and track those things for ED physicians who work all different shifts, right? Because we're all almost always after hours, except for maybe that really sweet 7 to 3 p.m. Shift, right? Otherwise, it's or you worked all the way overnight. So sometimes it can be tough to pick up. So I think physician satisfaction and formally measuring that counts for a lot, especially if that can help decrease attrition, retirements, which we hear these anecdotes, and we formally encourage people to tell us these things. And we've had physicians tell us, I was actually offered a job at another place, but they didn't have ambient, and they didn't have scribes either. So I'd rather stay here. And that, the SFB encounters, there's, I think, estimates of like 500,000 plus, cost to recruit a new physician, typically, depending on the organization. So those are all real hard dollars that hopefully will translate to financial people supporting, these new tools for us all to practice more efficiently and help give us back. I generally believe that some of the more joy of medicine that we've kind of lost with all this information or data overload this past decade.
Yes, yeah. I had neglected to mention during this very fast-paced hour that we were going to have we do have a Q&A session, and I was going to ask for questions from the audience and incorporate them into the conversation. The questions we have had sent in to us, I have kind of incorporated into what we've been talking about right now. I do see we're almost at the top of the hour, which is kind of, as I said, this is something we could talk about forever, because it's a very timely and a very important topic, and it's one where there's a lot of potential, a lot of the ills of healthcare can be seen through the ED, and a lot of the potential for improving healthcare can be seen in how you're using new technology and innovation in the healthcare space. Excuse me. With the couple minutes we have left, I'm going to ask this one last question of all three of you. Is what is the biggest improvement you're seeing through the use of technology in the ED space? What's the one big invention we've got going for us right now that is improving ED care? And does this translate to the future? Is this the future of ED? David, I'm going to start with you.
Yeah, I think the biggest thing I'm most excited about, there are a lot of things, so it's hard to pick one. I'll try to leave some stuff for my fellow panelists to talk about, but I think it's the ability that AI has to allow us to be more personalized with our care. And in maybe just focusing on one small section, just in patient education, like I don't have to give a patient a canned pre-made educational set of chest pain instructions that doesn't say anything at all, really. I can give somebody something that is tailored to a 65-year-old African-American female with 5 grandchildren at home that she's the primary caregiver of, and to give specific instructions that relates to that person. And so it's the ability to be more personalized, in addition to all the other ways that technology hopefully will be allowing us to spend more time one-on-one with patients and less time documenting, so that we can actually connect on a human level more and do less bureaucratic stuff in general, and then ultimately give the patient a more tailorized, personalized care plan at the end of the day.
I like that. Yeah, especially in the ED, when patients are leaving, you got to make sure they know what they're doing when they're going home or wherever they're going. Perfectly. Alan, same question.
Yeah, echo David. I think it's AI, and I guess I'll touch on a part that I think we briefly mentioned here, but we didn't focus a lot on. But I do see a lot of potential with AI, in addition to all the things we talked about, right, with ambient, helping with documentation and everything. But it's maybe that next step of not only just helping with documentation, maybe not just summarization with a chart, and along the lines of personalization where David was going, but really helping us with decision support. At a much more sophisticated level, so it is personalized to that patient. It's got the latest evidence that we just don't have a chance of keeping up to date with. Medical knowledge is doubling. I think they're saying like every 72 days now. So no way we have a fighting chance. And especially in emergency medicine, there's just a breadth of pathology and problems coming in to us that I think AI can really help us there. Make sure we're delivering the best optimal care for that specific patient in a level of way that no human being could do by themselves or have the time for. And that's, I think, the new frontier over the next 5 years or so that I think we're all going to be helping to see what these tools can do, and I'm very cautiously excited about.
Nice, great. Anthony, I'm giving you the last word on this. What are you most excited about in the ED space for new technology and innovation?
Yeah, I mean, it's hard to choose one technology, and I think that there's just so much out there now that's changing, right? We have virtual care, we have AI, right? We have our new Epic tools or EHR tools or CRISPs or HIEs, whatever it is that we use. All of it is kind of coming together right now in this space. And to me, one of the things I'm most excited for is our residents, to be honest with you, the medical education system and our med students coming through. They get to be a part of this and see this, and a lot of them are really brilliant minds when it comes to technology already. A lot of us old folks, we had to get pushed and pulled or whatever to get to adopt all these things, but they've lived with this, they've worked with this, as the younger generation, and really I think are taking starting to take the next steps with it, and even teach our IT leaders some things about what can be done. So I'm excited about the new generation coming in medicine and taking those new technologies to new avenues and seeing where we can move things. I think it's going to be a really exciting time over the next 10 years or so.
Yeah, it's the potential is great. And I had mentioned at the beginning of this hour the ER that we saw in ER or Grey's Anatomy or wherever at medical shows. It's you saw very fast paced with the big whiteboard and people running around and doing things haphazardly, even because it's just so crazy. It's different. It's getting different now. It's getting better. These new technologies have the potential to create a little bit more order out of that chaos and to improve outcomes, to improve the experience for the patient, to improve the workflows for the providers. And let's just see if, I believe The Pit is starting season 2 next month. Let's see if there's any of these new technologies in that, or if we can lobby them to start showing us some of how these technologies are are really improving healthcare. Gentlemen, it's been fantastic. Thank you very much for this conversation, which certainly could have gone on a lot longer. And basically that is all the time we've had today. In closing, please note that our next Winning Edge program will be taking place next year, January 13th. We're going to be covering cybersecurity, yet another hot button topic, and it's going to be a very good conversation then as well. A live clickable link will appear at the close of this program that can take you to the registration page for that event. Remember to follow along this week, and I've mentioned I'm going to be writing up what we talked about today. I'm going to get a write-up in the next day or two, and then on Friday we will be posting the YouTube version of this so that everybody can see the entire event. And that can all be seen on our website, healthleadersmedia.com. I want to thank our three panelists today for an excellent discussion, and thank you to those in our audience for joining us and for participating. We hope you enjoyed this program. And we look forward to seeing you again during our Winning Edge program and other Health Leader events. Thank you very much.